At the outset, first let me thank both APOS and AIOS for giving me this opportunity. It's been a great pleasure coming here, and you don't have to listen to me, it's all recorded in there. So I will just start the video. You have the voice on, please. Excuse me. Perspective, and since our patients present very late with lot of comorbidity, I will use a series of clinically common presentations and some individual tough cases. When they present with this hard and brittle cataract, it is pretty easy because you can use any vertical chopping method and handle the case. However, if they present with these diabetic, hard and leathery cataracts with the unyielding backbone, I sometimes flip the nucleus over, attack that central attachment with my Phaco tip. But I think this maneuver should be done by experienced surgeons. The soft cataract, as you all know, is an oxymoron. The easiest way to handle it is to prolapse it and eat it, or you use the horizontal chop with this long tip ball chopper, as has been shown to me by Nato and Alex. I also use this ball chopper for mechanical cleaving in the posterior nodal cataract. Kindly concentrate only on the central videos, and this is the B-Hex ring from Suven Bhattacharjee. A fantastic device, gives you a hexagonal pupil of 5 mm, very easy to insert, very easy to remove, and look at the fantastic pupil post-op. And in the intumescent cataract, there are many ways to handle it to avert the Argentine flag. I, however, favor the automated decompression, wherein I attach my aspirating needle to the aspiration line of my Phaco machine and decompress the lens. You can use any gauge, but I prefer the 24 gauge. And even if you get the Argentine flag, it's no big deal. You can still handle it, as is shown in this case. Down here, I put in a 3-piece lens, of course. And these are cases of therapeutic keratoplasty where I have done Phaco. The one on the left is a phacomorphic glaucoma, which presented post-therapeutic keratoplasty. I'm doing a combined surgery. The one on the right is a post-patch graft. I'm doing a Phaco in a very advanced cataract, and this case got a very good result. You can see it got only a 3 diopter astigmatism, which I will take any day. And these are other cases of corneal problems, and this is a keratoglobus. This is a case of severe corneal opacity, and this is a post-crescentic graft in a Moran's ulcer, and I had to use tissue glue during the procedure. This is a very interesting case. He had an injury 6 years ago, and he had a sudden drop of vision over the past 1 month. On gonioscopy, we found that he had an intraocular foreign body, a retained intraocular foreign body. So we de-epithelialized the cornea, went ahead, tamponaded that foreign body with viscoelastic and removed it with a micrograsper. And he is doing pretty well, but probably I did a Phaco, of course, after that, and he would probably need a graft later on. This is another difficult case. In fact, he presented to us with a fungal ulcer and a phacolytic glaucoma. It took us 1 month to heal this fungal ulcer before I attempted the Phaco on this case, and as you can see, it was a very difficult surgery. Did a combined procedure, very difficult to get the rhexis. Somehow cut it, got a sizable rhexis, dislocated the nucleus into the antechamber, used an IOL, a hydrophilic IOL, as a scaffold, handled the nucleus. It was a very hard nucleus, as you can see. Thought there was cortex there, dislocated the IOL into the antechamber, realized the cortex was in the vitreous, put in a CTR, relocated the IOL into the posterior chamber, put in some triamcinolone, and post-op he is doing very well. And these are cases of phacolytic glaucoma wherein I use a IOL as a scaffold when the bag is so loose. And this is commonly done, nothing much to talk about. And these are cases of phacomorphic glaucoma. The main thing in these cases is you got to get a rhexis after decompressing the lens, and after that the handling of the cataract is pretty simple. And these are unanticipated subluxations of the lens. Herein, I usually after hydrodissection put in a CTR for horizontal stability, put in iris hooks at the rhexis edge for vertical stability. After that, it becomes like a regular case and you can complete Phaco very easily. And these are what I would call sins of the others, wherein these are faulty wounds referred to me by colleagues. I repair the wounds and then go ahead and do the Phaco in them. This is a very, very bad wound. As you can see, this was an inadvertent deep dissection during an SICS, and this was done at the same sitting. This was done the next day, and the cases do pretty well actually. And this is a very rare case, the only case that I have seen of a hexagonal keratotomy. He also had a narrow angle glaucoma, he had YAG PIs, he had shallow ACs, very dense asteroid hyalosis, very tough to manage, but did get a good result in the end. And these are my sins. This is a case of retinitis pigmentosa, wherein I did a Phaco 1 year ago and he came back with a severe capsular phimosis, and I had to use a bimanual technique to go ahead and cut that extremely thick anterior capsule. But he did improve from 5 meters to 612. And this is a case that I had done almost 10 years ago, a coloboma lens, wherein I put in a CTR in this lady. She did very well actually. Till 7 years later, she came back with this inferior subluxation of the lens. And I had to hook it superiorly. I had to hook that CTR complex superiorly to the sclera with these Prolene sutures. And as you can see, it was a good result. And these are some patient factors. This is a case which presented with gross proptosis, probably an IG4 disease. He had been having it for 12 years. He just wanted us to take out his cataract, and that's exactly what we did. And this is something that you will commonly see, these patients with head nodding, and you just ignore the head nodding and go ahead with the Phaco and all goes well. And this is something I'd like to talk about. This is a patient who was referred to me as a psychotic patient. We put her under GA and did both the eyes, both were hypermature cataracts, and she got a very good result. And can you believe it, 4 hours later when we pulled out the pad, her psychosis disappeared. So all along it was just a sensory cause. And these are cases of traumatic cataract with their varied presentations. And as long as you plan well and stay ahead of the game, most of these cases you can handle and give pretty good results eventually.